Good afternoon and a warm welcome to this webinar, Genetic Diagnostics in the Era of Next Generation Sequencing. So we are MedGenome, the leaders in genetic diagnostics in India. And today's session is a very special one for us because we have two eminent speakers lined up for you. So we have first off Sheila Nambudri, who will talk to us about exome sequencing, a start or an end to diagnostic odyssey. And our second speaker will be Dr. Sumita Danda, who will be talking to us about retrofitting genetic counseling for the era of next generation sequencing. And before we hand over to our speakers, I would remind the audience that if you have any questions or comments, please use the Q&A window of the chat of the Zoom interface, and we will be addressing those questions at the end of the session. And a recording of this webinar will be sent out to you in a week or so. So without any further delay, I would now request Dr. Srinivasam Vedantam, the Associate Director for Operations at Genome, who will be the moderator for this session, to take over and introduce our speakers and take this webinar forward. Over to you, Dr. Srinivasam.
Good evening, everyone. Very happy to welcome both Dr. Sheila Nambudri and Dr. Smita Danda for the webinar. And they both are illustrious speakers and stalwarts in the field of medical genetics. And I think we are, happy that, they both are here to talk about some of the cases and also better explain some of the nuances of medical genetics. Joseph, can you? Just to introduce Dr. Sheila Nambudri. She's the clinical professor and head Department of Pediatric Genetics, Amrita Institute of Medical Sciences and Research Center, Kochi. She did her MBBS with first class from Trivandrum Medical College, DCH from Institute of Child Health, Chennai. Completed her DNB in Pediatrics from Trivandrum Medical College. She did her MSc in Medical Genetics from Duncan Guthrie Institute of Medical Genetics, York Hill Hospitals, University of Glasgow with first class. She has set up the Pediatric Genetics Unit at Amrita Institute of Medical Sciences, Kochi. She is a task force member on Human Genetics and Genome Analysis Program for Department of Biotechnology, Government of India from 2017 to 2020. She's a Scientific Advisory Committee member of the Comprehensive Care Center for Neurodevelopmental Disorders, Sri Chitra Tirunal Institute for Medical Sciences and Technology from 2017. She's a reviewer for 4 international journals and 3 national journals, and she has published 168 national and international publications in peer-reviewed journals. Apart from that, she has many awards to her credit. To name a few are the Commonwealth Fellowship by United Kingdom in 2004, the Erasmus Mundus Fellowship to Ghent University on 2030, Dr. Epen Samuel Memorial Award for Best Research Paper in 2014 by Indian Medical Association AMS Kerala chapter, M.O. John Memorial Award for Best Publication in a peer-reviewed journal for research article published on skeletal dysplasia in American Journal of Medical Genetics by the Indian Association of Pediatrics Kerala in 2014, Dr. Munna Gekar Award for the year 2013-2014 by Indian Medical Association, presented at the IMA NATCON 2014. First prize for the first round of National 6th Pediatric Quiz for pediatric practicing pediatricians during Pedicon 2003 at Mumbai, and Dr. Bhaskara Verma Award by the Indian Association of Pediatrics Kerala for the best paper presentation during Pedicon South 1990. So today she will be talking on the topic. Can you just move to the slide, Joseph?
Yeah. So she'll be talking about exome start and end.
Exome, yeah. Dr. Sheila will be talking on exome sequencing, a start or end of diagnostic odyssey. Over to Dr. Sheila.
So can you see the slides clearly?
Yes, ma'am, we are clear. We can go ahead.
Okay. Thank you for MedGenome for this wonderful presentation arrangement. Wish you all warm greetings from Amrita Institute of Medical Sciences, and thank you for the kind words, Srinivas. Nowadays, exome sequencing is not at all a difficult investigations for clinicians because it is available in plenty in many labs. But some of the some of the results what we get can be very difficult to interpret, and I just want you to go through some of the nuances which we can encounter while we are while we are going ahead with some of the cases. So I thought that I will take you through around 6 case scenarios, which are all practical cases which were taken out from our clinical practice. So coming to case 1, this couple had come to our as for pre-conceptional counseling because they were non-consanguineous couple. They had only one child who had expired at the age of 11 years. And this girl had severe hypotonia, weak cry, and muscle wasting. And there was no associated feeding problems. She had global developmental delay, and she had neck muscle weakness also. And the global developmental delay, even though she had global developmental delay, she was somewhat she was attending school, and she was going to 5th standard. She could read and write, but not up to the mark. The investigations which were done at that point were, one was muscle biopsy, and this muscle biopsy was done from NIMHANS, and it had shown that the features were suggestive of congenital muscular dystrophy. At that point of time, it was done long time back. At that point of time, immunohistochemistry analysis was not done. The other investigations which were done for the girl include nerve conduction velocity, which had shown a mildly reduced amplitude from the both peroneal and also from the median nerves, and electromyogram had shown scanty evidence of denervation potentials from the right deltoid. And the total creatine phosphokinase was elevated. It was 1602, the normal being up to 200, and her CT brain and echocardiogram was normal. So this is the pedigree, and this is the proband who had come. This is the proband who had already expired. Actually, this family had visited us around 1 month after this child had expired. So the couple were non-consanguineous. Once we went ahead with the detailed history taking, the father's elder brother and one younger brother were also having a muscle problem. So I had asked, because we did not have the DNA of the affected child and the parents were non-consanguineous, I thought that it is better to go ahead with the father's elder brother because he was also having a muscle disorder. So the elder brother was 48-year-old person with normal intelligence. He was apparently normal till the age of 23 years. At 24 years, he developed difficulty to climb the hill. And at 30 years, he had difficulty to climb onto the bus also. And over the next 2 years, he had developed weakness of the upper limb, and there was progressive wasting of the upper limb and lower limb. By 43 years, he had become wheelchair bound. On clinical evaluation, he was having generalized wasting of the upper limb as well as lower limb. In the upper arm, the wasting was more on the upper arm. He was unable to make a fist. So obviously, he was having weakness of the proximal muscles as well as distal muscles. And the hand grip and interosseous were also weak. The facial muscles were spared, and there was wasting of the thigh and anterior compartment of the muscles. And foot and dorsiflexors and plantar flexors were also weak. And his creatine phosphokinase was also elevated. You can see that it is 1538. And he also had scoliosis. And then we checked his younger brother also. His younger brother was 41 years old. He also had normal intelligence. There was a history of poliomyelitis at 9 months of age, and he had weakness of the right lower limb. So he always had weakness of the right lower limb, and he used to walk by dragging the right leg. At till 28 years, he did not have any other involvement of any other limbs. But at 28 years, he had developed pain in the left upper limb, and gradually he developed buckling of left knee. And at 31 years, he had developed weakness of the left lower limb, and now he is having difficulty to raise the upper limbs also. And he also had a similar presentation as his elder brother. He also had generalized wasting of the upper limb and lower limb, and he also was unable to make a fist and also had a poor hand grip. And the power in the upper limb and lower limb were only 2/5. And his muscle biopsy was done from elsewhere, and it also had shown a muscle dystrophy, and the CPK was 2646. So after going through the family history, the father of the proband, we have checked him in detail, and he was completely asymptomatic, and he had a normal CPK of 96. So for the first person who had undergone investigation was the elder brother, and at that point of time, we had done a muscular dystrophy panel at that point of time, because this whole exome sequencing was not very easily available at that point of time, and he had homozygous mutation in the DYSF gene, which is responsible for dysferlinopathy. So once we got this mutation, as a second step, actually this family was having lots of financial constraints also. So we tried to do it in a simplified way. So the same mutation was checked in the father of this child. So this father was a carrier for this mutation. And the mother was also checked. That means the child who had expired, that the proband's mother and father were checked for this. The father was having, he was having the mutation in the heterozygous form. The mother did not have the mutation in the heterozygous form. So they were non-consanguineous also. So there was no other way. We had to do a medical exome for the mother also at that point of time. Once we did the medical exome of the mother was found to be a heterozygous carrier for LAMA2 gene. So this LAMA2 variant is responsible for myosin deficient myopathy, and that was detected in her. So at that point, the lab people told me that the person whom we have investigated prior to this, that is the elder brother of the husband, he also had a heterozygous mutation in LAMA2. So at that point, the same mutation was there in the husband's elder brother also. So the mutation was checked in the, once we had done once we were aware of this mutation, this same mutation was checked in the father of this child. So the father was also positive for LAMA2. It was very surprising because the two elder brothers were homozygous for dysferlinopathy, whereas the father of the child was he was a carrier for two disorders. One is dysferlinopathy and another one was LAMA2. So the message from here is retrospective evaluation of a couple following death of an affected child would be really challenging. So this is a very, very important message I want to convey. So whenever we have a child who is having for whom we are suspecting a genetic disorder, even if at that point of time, if you are unable to do the test, it is extremely important for us to save the DNA, so that at least at a later stage we can offer prenatal diagnosis for that couple, or we can confirm the diagnosis at a later stage. And the second message what I want to give is two muscular dystrophies can coexist in the same family in the first degree relatives. So actually, I think even though I have been working for more than 16 years in the Department of Genetics, I think this is a very surprising thing what I have seen. And muscle biopsy should always be combined with an immune histochemistry. Actually, if an immune histochemistry had been done at that point of time, because it was not available at that point of time, but what I'm telling is, if it had been there, it would have shown that this is a myosin deficient. There is a myosin deficiency. If we had got such a result at that point, it would have been little more easy for us. So storage of DNA is always advisable for undiagnosed patients with suspected genetic disorder. Coming to case 2, this is a 7-year-old boy who is the first child who was born to non-consanguineous couple and is proven with a condition called epidermolysis bullosa dystrophicains. This was a clinical diagnosis. He was not subjected to any genetic study at that point of time. And he had extensive lesions all over the body, and also he had contractures of all fingers, and he had fusion of toes, or otherwise called as syndactyly. So when the mother got pregnant for the second time, and a prenatal diagnosis was done by doing a clinical exome from elsewhere, and the fetus was found to have a compound heterozygote mutation in exon 111 and exon 11 of COL7A1 gene. But at that point, the parental segregation was not done. Actually, this was not done from anywhere from our lab, so our center. And simultaneous, actually the person who had sent the sample of the fetus had simultaneously sent the sample of the proband also, and the proband was found to be having a homozygous mutation in exon 111. Because there was a disparity, this was a completely unexpected result. The fetus was having two mutations, one mutation in one heterozygous mutation in exon 111 and another heterozygous mutation in exon 11, whereas the elder child who is affected with epidermolysis bullosa is having a homozygous mutation in exon 111. Because of this disparity, this family was referred to us for interpretation of the exome results. So this is the report. This is the report of the fetus. In the fetal sample, we can see that there are two mutations, two heterozygous mutations. The first mutation is likely pathogenic one, and the second one is a VUS mutation. And maternal cell contamination has also been ruled out. And this is the proband, where you can see that the proband is homozygous for epidermolysis bullosa dystrophicains, which is a likely pathogenic one. So the next step, what we'll have to do for unraveling the problem is, we'll have to do a parental segregation. So we had done a parental segregation. It had shown that the father is having a heterozygous mutation in exon 111 and another heterozygous mutation in exon 11, whereas the mother was having only a single heterozygous mutation in exon 111. And we did one more test in the proband, and we checked that, because even when we are seeing something like this, for people who are from the pediatric side, I just want to explain one more thing. So once you see two mutations like this, both these mutations can be present in a single chromosome, or it can be present in different chromosome. If both the mutations are present in single chromosome, that person will not have any clinical features, whereas if both are present in two different chromosomes, it is otherwise called as trans, and then the person can have symptoms. So this father is completely asymptomatic. So what we did was, the affected child, we had checked whether this child is having a mutation in the heterozygous mutation in exon 11 or not, and it was not detected in the first affected child. So this variant was present only in the fetus and in the father in the heterozygous state. So as the proband is the first child who is severely affected, as the proband did not carry the variant in exon 11, we can be certain that these variants are present in trans in the father. That means in both in two different chromosomes. So father is completely asymptomatic in spite of having variants in exon 11 and exon 111, and that shows that the variant in exon 11 is a variant that it's a completely benign variant. So from this interpretation, we have given a letter saying that this fetus has inherited exon 111 from the mother and exon 11 from the father. So it is exactly like the child is having a child. It is quite unlikely that the child will be affected with epidermolysis bullosa. So here, the message what I want you to go through is, never ever try to do prenatal diagnosis without confirmation of the diagnosis in the proband. That is the first thing. And second thing is, always offer prenatal diagnosis after doing parental segregation, because once we are having some confusion during pregnancy, it is extremely stressful period for the family, and it might be it will not have too much of time to sort it out also. Going through case 3, this is a family they are third degree consanguineous couple, and this is a child whom I had seen long time back. I think I had seen this child in 2007. So actually now recently in 2016, I had seen the second child, and the second child is she was born to a third degree consanguineous couple. She had a normal birth weight of around 2.3 kg. The elder sibling was a proven patient with MPS 3A or Sanfilippo type 3A, Sanfilippo A. So at that point of time, we did not have any genetic tests with the mutation analysis was not freely available. We were sending amniotic fluid samples for enzyme analysis to elsewhere. We were sending it to Netherlands, and we were doing it. So at that point, we had ruled out MPS 3 in this girl. So, and the family were assured that this child is not having mucopolysaccharidosis type 3. at the age of this girl was near normal till 1 year 4 months of age, and she could say a few words, and she was able to transfer transfer objects, and she was also able to walk with support, and she developed pneumonia at that point of time, and she was found to have torticollis and neck floppiness just after recovering from pneumonia, and she also had a stooping posture while sitting. Then I had not seen this girl. This was the history what the parents had given, and this girl was lost for follow-up, and she was getting consultations from a different place. And at 6 years of age, she had visited our hospital once again. And at that point, she did not have any head control. There was no speech. She did not have toilet control. She could only turn over. There was severe generalized hypotonia, and she did not have any corneal cloudiness, or she had a normal fundus. There was no hepatosplenomegaly. In fact, there was history of seizures from 4 years onwards, and she was on anti-epileptic medication. So this is the scan which was taken at the age of 6 years. You can see that there is generalized brain atrophy, and she was having bilateral hyperintense putamen and caudate nucleus with sparing of the there was severe hyperintensity of the putamen, and there was sparing of the caudate nucleus. There was active disease in the occipital region also. So with this possibility, and she was also having a cerebellar atrophy. This is about the first child. This first child I had seen long time back at 4 years of age. He was having a birth weight of 3.4 kg and had seizures at 9 months of age, had global developmental delay, coarse face, hypertelorism, and clinically he was having features consistent with mucopolysaccharidosis. The urine glycosaminoglycan was very high. It was normal is up to 112 when he had 323. And urine electrophoresis had shown heparin sulfate 3+, and heparin sulfamidase enzyme analysis was extremely low. With this, we had made a diagnosis of Sanfilippo A. And this was the photograph of the child at that point of time. And this is the photograph at 11 years, when now he is tube fed and he's having severe spasticity of both lower limbs. So at 11 years, he was initially at 5 years, he was able to walk, even though he had unsteady gait, and he had global developmental delay and speech regression and seizure. He had seizures from 9 years of age, and currently he is at 11 years, he is wheelchair bound and with a head circumference of 56 centimeters. And these are the x-rays which are taken at 11 years of age. We can see that the ribs are very, very broad. It is otherwise called as the oar-shaped ribs, which are fitting in with mucopolysaccharidosis type 3. And there is medial broadening of the clavicles, which is also a feature of Sanfilippo. And this is the proximal tapering of the metacarpals from 2nd to 5th metacarpal. And we can also see the tapering of the lower ileum. So all these features, and with irregular carpals, and there is a gross delay in bone age at 11 years. So all these features were fitting very well with mucopolysaccharidosis. So at this point, I had discuss this case with Dr. Girisha, who is a good friend of mine from Manipal. So both the children as well as the parent sample were sent, and they have done a whole exome sequencing for the whole family. So at that point, it was a big surprise that both these children were having homozygous mutation in SPG11, which was consistent with spastic paraplegia 11, and which is an autosomal recessive disorder. And it had also shown that the parents were heterozygous carriers for the same. And for the mucopolysaccharidosis, for MPS IIIA, the gene is SGSH. The boy was homozygous for that. The girl was heterozygous, and the parents were both the parents were heterozygous for that. And the third surprising thing is that this girl was having a heterozygous variant of in NDU-FAF6, which is responsible for Leigh syndrome, which was actually our clinical suspicion was mitochondrial Leigh syndrome from the clinical features and from the scan also. So it was Leigh syndrome due to mitochondrial complex 1 deficiency. The mother was having a heterozygous mutation, and to our big surprise, the father was having a completely different mutation in the same gene. So this girl was a compound heterozygote for Leigh syndrome. So both these children were having blended phenotype. The girl was having spastic paraplegia type 11 and mitochondrial complex 1 deficiency, which was nuclear type 17. And her elder brother was having spastic paraplegia 11, and mucopolysaccharidosis type 3A, and parents were carriers for all three conditions. So the message what I want to give is that consanguineous couple could be heterozygous carriers for more than one gene. We have yet another family where the first pregnancy they had osteogenesis imperfecta, and in the next pregnancy they had spondylocostal dysplasia, and in the third pregnancy once again they had osteogenesis imperfecta. So that couple where they were also consanguineous and they were carriers for two different disorders. So the couple should be informed. So whenever we are counseling the autosomal recessive couple, or consanguineous couple, we should always tell them that there is a slight possibility that they might be inheriting some other autosomal recessive disorders, which we are not sure at that point of time. Coming to case 4, this is a 28-year-old non-consanguineously married woman. She had come for prenatal counseling at 5 weeks of pregnancy. She had a 4-year-old son who was diagnosed with thalassemia minor by hemoglobin electrophoresis. Why this was done was that at 1.5 months of age, his hemoglobin had dropped to 6.5 grams. And he had required transfusions twice in his life till 4 years. So at that point, at 1.5 months, he had a hemoglobin of 6.5, and at 2 years he had another instance when his hemoglobin had gone down to 7.5 gram. So the parental hemoglobin electrophoresis was done, which had shown that the mother was a beta thalassemia carrier as the boy, but the father was not having beta thalassemia carrier status in the father. It was not there. There was no family history of any other chronic anemia or history of blood transfusion. This boy had pallor, and he also had hepatosplenomegaly. And he was investigated because he was not for thalassemia minor patients. We are not expecting severe anemia, or we are not expecting that they would need a transfusion, and he needed transfusion at 1.5 months of age. So this is the evaluation of the couple along with this child. Here you can see that the hemoglobin F in the boy was 4.2, and his hemoglobin A2 is 5.5. And in the mother, the hemoglobin A2 was 4.9. So this shows that both the mother and son, both of them are thalassemia trait. And the MCV, MCH, and MCHC were all, it was low for the mother as well as for the son. And whereas for the father, he was perfectly normal, and he had a hemoglobin of 16, and he had a hemoglobin A2 of 3.2, and he had a normal peripheral smear picture. Once we did the mutation analysis, the mother was a heterozygous carrier for beta globin gene, and the son was also having heterozygous mutation, whereas the father did not have a mutation in the beta globin gene. And at that point, the alpha globin gene had shown a triplication in the father. So this child was having a heterozygous mutation in beta globin gene, which was inherited from the mother. Along with that, the child also had an alpha globin gene replication, which was inherited from the father. So this had led to a beta thalassemia intermediate phenotype in this boy, and that is the reason why this boy needed transfusions. So the message here is that alpha globin gene replication, it can be seen in normal persons also. Somewhere around 1% of the people can have alpha globin gene replication, and this does not have any implication, because you know that the father was also having this alpha gene replication. He did not have any problem. So presence of extra copies of alpha globin gene can worsen the degree of anemia in beta thalassemia heterozygotes. So that's a message here. So co-inheritance of triplicated alpha globin gene should be considered in apparent beta thalassemia carriers who are more symptomatic than expected. Now I'll take you through another scenario where I will tell you the importance of taking a detailed history. So here, this was a 6-month-old girl. She was a first child born to non-consanguineous couple with a birth weight of 2.8 kg. There was no history of birth asphyxia. And at 6 months of age, she came to our institution because she had global developmental delay. There was no head control. There was no social smile, and she had poor suck. And there was history of one seizure also. And one history what the mother had given to us at that point was that she told me that whenever this child is getting any vaccination, she had noticed that this child will never cry. So that was one important history that she gave. So the head circumference was less, it was only 41 centimeters, and the child had a weak cry and hypotonia, and the power was also less, it was only 3/5. And so here on clinical evaluation, we could see that the child was insensitivity. The child had shown insensitivity to pinch. The creatine phosphokinase was normal, the nerve conduction velocity was normal, and VEP had shown reduced waveforms from both eyes. The auditory evoked response was normal, MRI brain and microarray were also normal. So this sample had also been evaluated from Manipal from under Dr. Girisha. So here they found out that this child was having a heterozygous mutation in EBF3 gene. We are seeing this particular variant for the first time. This is a likely pathogenic de novo novel, and we also checked the parents, and the parents were not carrying that's why it has become de novo. So just because of this history, we were able to confirm that this is because in a clinical scenario, what we should understand is that when we are getting a gene which has never been described, or when we are getting a variant like that, it is not possible for us to do the functional study on clinical setting. So here what happened is in EBF3 neurodevelopmental disorder, it is a newly described condition. Only very few patients have been described. This EBF3 mediated transcriptional dysregulation can cause intellectual disability and global development delay and hypotonia. It has been seen in around 0.1% of individuals with unexplained neurodevelopmental disorders. And one of the important feature in this condition is altered pain sensitivity, and they can have only bigger children have been children beyond the age of 10 years have been described. Our patient was only 6 months of age, and self-injurious behavior has been shown to be a feature of this disorder, and they can present with autism, stereotypic behavior, stereotypic movements, ataxia, and behavioral problems and facial dysmorphism. This is the last scenario. This was a 10-month-old girl born to first degree non-consanguineous couple with a normal birth weight and normal development. And this child just had a perfectly normal baby and had a fever and loose stools and drowsiness for 2 days duration, and had one episode of hypoglycemic seizures, and the GRBS had gone down to 25 milligrams per deciliter on first day of illness. And actually this patient was referred to our liver transplantation unit because this child had grossly deranged liver function tests and PTINR values. So at the time of admission, the child was very drowsy and was opening the eyes. She was very drowsy, but was opening her eyes to call. She had deep icterus, hepatosplenomegaly. The liver was 3 centimeter, which was palpable down the right costal margin. The spleen tip was palpable, and other systems were within normal limits. The investigations had shown that initially she was having a bilirubin of 3.2 with a direct 1.8, and her SGOT values and SGPT were very high, 2,500 and 3,500. And the PTINR also showed that she has the severe derangement in the clotting factors, and there was no clot detected, and APTT was also very much elevated. So the viral panels, the viral panel were normal, the TORCH IgM was normal, her IgA ANA panel was normal, dengue and leptospira were normal, and the rest of all these investigations did not show a particular pattern, and liver biopsy had shown variable portal inflammation and focal lobular inflammation. So with that feature, she was treated symptomatically, and gradually the liver enzymes came down after 10 days. On day 10 of admission, her bilirubin had come down to normal, and her SGOT and SGPT had come down to 48 and 220. On follow-up, 1 month after admission, her SGOT and SGPT had come way back to normal. So then she had, after 1 month, she had a second attack, which was exactly similar to this. And at after the second attack, she was considered for liver transplantation. Then nobody knew what is happening for this girl. So at that point, we had sent her sample for a genetic evaluation also, and the whole exome sequencing had shown that this was sent to mid genome, and at that point of time, it was identified that she was having a homozygous mutation in NBAS gene. This is a 3 base pair deletion, and the parents were heterozygous carriers. The parents were non-consanguineous. Mutation in NBAS gene can lead to recurrent liver failure during febrile illness. Actually, this is it's an extremely rare disorder, and actually, after seeing this diagnosis, we decided that there is no need for any liver transplantation. So the point is that just because this condition was diagnosed, we had given an emergency management schedule for this family. So just because she had liver failure with each and every, multiple episodes of liver failure, what happens is when such a person is admitted in a hospital, the doctors will be reluctant to give her paracetamol because that can aggravate the liver toxicity. So, but in this condition, this is the protocol that should be followed. The paracetamol should be given for these patients as soon as they are having fever. They should be treated promptly, and they should also be given domperidone, and high dose of glucose, 10% dextrose with electrolyte should be given, and syrup carnitine should be started at that point of time. And intravenous administration of lipids are also advised. And during follow-up, till now, she had altogether 6 attacks till date. Actually, the time when we are doing this presentation, she has been admitted in our hospital for now she's admitted with the 6th attack. And every attacks were treated symptomatically in the follow-ups also. In every admissions, they were treated symptomatically. Currently, she is 4 years, 4 months of age. And here the latest, her SGOT, SGPT were 9,000 and 6,000 and with no clot detected. And after 5 days of admission, everything has come back to normalcy. So recurrent liver failure due to NBAS deficiency, the name of the gene is neuroblastoma amplified sequence gene. So this is a novel cause for acute liver failure with the onset in infancy. The liver crises are triggered by febrile illnesses, and liver failure is precipitated after 1 to 2 days of fever, and they become less frequent with age, but it is not restricted to childhood. And complete recovery is usually seen, but acute liver failure can be, sometimes it can be fatal also. So the most important thing is that the antipyretic therapy and induction of anabolism, including the glucose and parenteral lipids, should be started as soon as the patient is having fever. And the reason why this NBAS is precipitating, this mutation is precipitating the liver failure at the point of fever is that the NBAS is a component of the transport vesicle, and the thermal susceptibility of the syntaxin 18 complex is the basis for fetal dependency in acute liver failure. So till now we have decided that there is no need for liver transplantation. A joint discussion has happened 2 or 3 times for this girl. Whenever she was admitted, there was a team discussion happening between the transplant team, with the gastroenterologist, and with the genetic team. And when we had gone through the literature, liver transplantation has been tried in 1 patient for this disorder. So to sum up, proceeding to do the prenatal study without genetic confirmation in the proband is like searching for needle in a haystack. And DNA storage of affected children with undiagnosed disorders should always be encouraged for future confirmation. So even at that point, if the family are in a position, if they cannot afford to do a test at that point, at least we should do storage of the DNA. And parental segregation should always be done before offering prenatal diagnosis, and consanguineous couple could be carriers for more than 1 single gene disorders. I think with this, I'll stop the presentation. And if there are any questions, I'm happy to take it.
Thank you, Dr. Sheila. I see a couple of questions being asked in the window. One question is, since parents can be carriers of same mutation in spite of not being related, what is your opinion on a premarital genetic testing of couple if they request for test?
Actually, some consanguineous couple, they come and ask for genetic test. Actually, I have done that the testing I have done for consanguineous families, but I think I have burned my fingers. The couple were carriers for 5 or 6 disorders. So after that, I have never ventured to do a pre-marriage, something like a before pregnancy, I never advise them to go ahead and do the test, because we are not sure whether that is a significant one. How do we know? Because unless there is a phenotype, or unless they have a child who's affected, we can't be sure that a mutation, even if you are seeing a mutation in dysferlin gene, how can we say that unless it is a known mutation, we can't be sure. It can be a VUS, then that will bring only more confusions. I don't think, personally speaking, I will never do like that.
The next question is, how would you proceed with management of a patient if detected with homozygous VUS mutation in a candidate gene?
Homozygous VUS mutation in the candidate gene, and what about the so definitely the first and foremost thing, as I've told you about the approach, there should, whenever you see whenever you send a sample to a lab, you should always give the lab a detailed clinical diagnosis, what you are thinking, your first diagnosis, second diagnosis, and third diagnosis. So if it is fitting in with your clinical suspicion, so for example, if you are sending a sample for a muscle disorder and you are getting a mutation in the homozygous state, even if the lab is reporting it as a homozygous VUS, then the first thing what you do is, then you will do a parental segregation, and you will see whether the mutation is there in the parents or not. That's the first thing. If you are getting a mutation which is homozygous, and if it is not at all fitting in with the clinical features in this child, I don't think that I will give much importance to that. It all depends upon whether the homozygous mutation is having some phenotypic similarity with the presentation in the proband. That's it.
The next question is, how does the globin gene triplication initiate the beta thalassemia carrier gene to express in the offspring?
No. Alpha triplication, alpha gene triplication, alpha gene triplication is it is not a very serious disorder. It can happen in only 1% of the cases. Actually, this workup this is for the first time I'm hearing a thing like that. And we had sent the sample to Vellore, and from CMC Vellore only, they suggested that when a patient is having a feature like this, and when the patient is having something like a beta thalassemia trait, and if the patient is having anemia which is disproportionate to the clinical features, then we should always check for the alpha thalassemia triplication. The exact mode, I think it is truly speaking, I now I just forgot what the exact mode, how it interferes with the beta globin gene. But there's a mechanism. I think if the person who had asked this question, if you can send a message, if you can send an email to me, I can clarify that point.
Thank you, madam. Thanks a lot once again. I think it was a very comprehensive talk. You have covered different cases with different scenarios where genetic testing was of utmost utility, and very clearly explained why extensive clinical history with pedigree is very critical when we actually prescribe for genetic testing, and the utility of the exome sequencing, next generation sequencing in arriving at the right diagnosis. Thank you once again, madam. Let's move on to the next speaker. Extremely happy to introduce Dr. Smita Danda. She's the professor and head clinical genetics unit, Christian Medical College and Hospital, Vellore. She did her MBBS and MD from GSVM Medical College, Kanpur, DM Medical Genetics, SGPGI, Lucknow, advanced training in clinical genetics in Women's and Children's Hospital, Adelaide. She's the PI for training clinician, the skills of clinical genetics and screening of antenatal mother and newborn screening in aspirational district of Washim, clinical trial in Gaucher disease and Pompe disease, registry for Gaucher, Pompe, Fabry, and mucopolysaccharidosis type 1. She has got 95 national and international publications in peer-reviewed journals to her credit. She has written 2 book chapters. Her special interests are in dysmorphology, autoimmune disorders, metabolic genetics. Her awards and associations, she has got the G.P. Elhens Award for Best Postgraduate in Medicine, Senior Training Fellowship at the MGH and BWH Boston under Harvard Medical School and Molecular Laboratory under the Harvard University. She's a life member of Indian Medical Association, life member of Indian Society for Human Genetics, for Mitochondrial Research, and life member at the Indian Academy of Medical Genetics. Over to you, Dr. Smita.
Thank you very much. And I thank the organizers. Am I audible?
Yes, madam. Yes, madam, you are audible.
So can you see my slides?
Yes, we can see your slides, ma'am. You can go ahead.
Are they moving? No.
Yes.
Yeah, so today I would be again discussing some case scenarios as Dr. Sheila has already laid the background, and retrofitting genetic counseling for the era of next generation sequencing and how we have experienced in CMC Vellore. So traditionally, genetic counseling was for single gene disorders where we had to describe the recurrence risk. There was a component of privacy and confidentiality, and it would be non-directive. So with the new next generation sequencing coming into place, we have new findings and which have to be incorporated while proceeding with genetic counseling. And we will sort of complete the puzzle which the family are seeking for a long time. So as we know, next generation sequencing has been a boon in many ways, but it is complex as well because it gives rise to a lot of complexities and thousands of scenarios can come up. And therefore, the approach has to be very different and it has to be case by case basis. So if you take typically, Sanger sequencing used to involve single gene. So either you are looking for the variant which you are dealing with the disease, and or there will be no variants in that gene if it is not the same or the correct diagnosis. Whereas now with targeted panels, you have more genes and more variants. So clinical exome, approximately 5,000 genes, and similarly proportional variants will be seen. Whereas for whole exomes, about 17,000 to 18,000 genes, and obviously there are going to be more variants. And it would be exponentially increased for those which have whole exome sequencing, where you also do the introns, which are forming a large part of the DNA. So I will be outlining some case scenarios and would try to emphasize what is the importance of family history, correlating the phenotype or retrophenotyping, thorough literature search, bioinformatic tools, segregation in family, biochemical parameters and other evidence for a diagnosis, functional studies, non-Mendelian inheritance such as mitochondrial or imprinting, and incidental findings, last of all. So what was the difference in genetic counseling in the two eras? Prior to NGS, the traditional genetic counseling focused on target gene and its natural progress with respect to disease risk. And after NGS, since there are several genetic variants which can be identified, each with a different function and different consequence, so every counseling session has to be case-based. So let's see of case 1. This is Master P, 8-year-old boy of non-consanguineous marriage, presenting with the global delay, behavioral issues, dysmorphic face, some high arch palate, inverted V shape of mouth, elongated face. And this is a little sister who is 2.5 years old. Though she has some speech and her other milestones are normal, but she sort of speaks jargon and keeps occupied to herself, and she does not really make much eye contact and is very hyperactive. So these are the 2 cases which were referred from our pediatric neurology, and this was the initial pedigree which we had got from them. So they are non-consanguineous. These are the 2 siblings. We do not know whether they have the same thing, and there's a spontaneous abortion also. Now, when they came with this clinical exome report, which was already done, so this was a VUS in this gene, which is for Joubert syndrome, and there were no other variants. So if we see that this variant doesn't really match with the phenotype, as previously MRI, everything had been normal for these children. And so we had to trace back the family history again. And then we came to know that there is another maternal cousin who has a similar problem, having behavioral issues, and they are also showing in our hospital. And luckily, they had been seen by one of us and in the medical genetics department. And that time, because of his facial features, we had ordered for Fragile X syndrome because of his autism and other behavioral issues. So this child was having more than 2000 repeat in the FMR gene, and therefore this child was having Fragile X syndrome. Now you see that if we trace the clinical exome and go back on that, then we will not land up anywhere, because the method of testing for Fragile X syndrome is very different. So it is a triplet repeat disorder, and it has to be picked up by a method called triple repeat PCR or TP-PCR. Therefore, the genetic counseling has to be accordingly. So we have to order for the sister as well as the mother and the aunt, or whoever are affected or who are likely to be affected or be carriers for this disorder. So this was case 1. Now seeing case 2, this is another 10-year-old girl referred from pediatric dermatology with skin lesions and short stature. So this girl had been evaluated in dermatology. She was born of consanguineous marriage, and she had no other developmental problems, but they had noticed hypopigmentation as well as nail pigmentation, and she was having a delayed growth also. So this child was evaluated by dermatology, and before coming to us, she already had a report. So this is the child. You can see the extensive pigmentation, which is all over the body, the tongue, and she had been tested for Addison's also, which was negative, and the diagnosis elsewhere by a skin biopsy had been dyskeratosis congenita. But she was also a short girl and having compromise in her growth. So initially, the report which she carried with her was the testing was done for skeletal dysplasia and dyskeratosis congenita along because of the short stature and the skin biopsy showing this sort of a finding. So what was found was that there was a gene called the SMARCAL1, which is associated with Schimke's disease. Schimke's disease is a disease where you have um, uh, renal problems as well as cafe au lait spots and immuno-osseous dysplasia. There is immunodeficiency as well. So since this child was not having such phenotype, therefore it was not really likely that she was having this problem, and this is just a it was a heterozygous variant. So the phenotype was not matching, and therefore after counseling, we have planned whole exome sequencing, and the report is still pending. So we have to have a correct phenotype match, which is matching with the variant which is found. So this is the message which we see from this case. This is another case which has, which is a 15-year-old boy, consanguineous marriage, presented with clinical indication of joint contractures, bilateral congenital talipes equinovarus, webbed elbow, and wheelchair bound. He never walked, he had been wheelchair bound. He is the only child of the consanguineous parents, and he was suspected to have arthrogryposis with pterygium. Subsequently, when we did the whole exome sequencing, a pathogenic variant was found in the FKBP10, which is associated with osteogenesis imperfecta as well as with Bruck syndrome, where you can have arthrogryposis and webbing. So genetic counseling was done accordingly, and validation for the parents was ordered, and it was expected to be heterozygous for the parents. But surprisingly, the father is homozygous and the mother is heterozygous. On examination as well as history, the parents are asymptomatic. So that raised a lot of queries that whether this could be the actual variant which we are looking for. So a thorough literature search had to be done, and it was found that there is one paper reported. In fact, Girisha is also the corresponding author in this, and there he has studied. They have studied OI, osteogenesis imperfecta cases in Indian families, and this particular variant has been reported from mild to lethal. So, because of this spectrum which it can cause, we thought that this is relevant, but still there are certain issues which are unexplained and more evidence is needed. Maybe functional studies if possible, but this is a case which shows that parental validation is essential to give significance to a variant. This is case 4, where we have a 14-year-old boy diagnosed with Wilson's disease in AIIMS, and where targeted gene sequencing was done for the ATP7B gene. And what was found that he is a compound heterozygous for the pathogenic 2 variants. And the parents' sequencing was also done, and they are carriers of 1 variant each. Now, he has a younger brother who has developmental delay, seizures, hyperactivity, slurred speech. So this boy was also brought in, and the proband, which already had a diagnosis of Wilson's, he was also not responding so much to the medicines which are usually given for Wilson's. He's continued to have speech delay and slurred speech. So he was evaluated and sent to us from pediatric neurology to look into it. So if you see that this is the proband, this is at a younger age, and this is when we saw him. So you can see the typical dystonic posture, but along with it, you can appreciate there is a lot of dysmorphism. There is telecanthus, there is thick lips, these are some low set ears, and they had macrocephaly. So this is the younger brother who also had seizures, and he had these issues, and he also had a macrocephaly, but not very typical or similar to his brother. So suspecting that there may be something more, a chromosomal microarray was done first in the proband, and that detected a copy number variation with a deletion in chromosome 5. So there was a 12.7 megabytes loss in chromosome 5, and when that was done, then an array was done even in the younger sibling, which showed a gain in the same similar region, indicating trisomy for this region. So even for the Wilson's disease, the brother was tested and he was not found to carry any of the variants. So he had just this copy number variation. So here there is this one child who has Wilson's disease as well as a copy number variation, while his brother has only a copy number variation, which is a gain. So testing in parents is definitely recommended, and a karyotype testing would pick up if there are any translocations which are segregating like this in their children. So you see that there is a multiple genetic factors and a blended phenotype which has caused this problem. So the counseling has to be catered in similar way for the proband as well as for his sibling. So this is case 4, where we have a 16-month-old boy, first born to third-degree consanguineous parents with developmental delay, macrocephaly, extended neck, and you can probably appreciate the Coase face that he has, some hirsutism, the supraorbital ridges, and there is this neck extension, the thickened ear lobules, and the Mongolian spot, and a slight gibbous which was there. His urine mucopolysaccharides was strongly positive, so he was in the category of the MPS or storage disorders. So for this, we had differentials like Hurler syndrome. Then, of course, there was MPS type 6, that is Martolame, and MPS type 7 or Sly syndrome. So the eye examination showed a sort of a corneal haze, which made Hunter syndrome or MPS 2 less likely. And you can appreciate the dysostosis also was prominent. There was tapering fingers. You can see the O-shaped ribs, which Dr. Sheila has already shown, and the flared iliac bones and the epiphyseal abnormalities. So there was a borderline hepatosplenomegaly on ultrasound abdomen. So with this sort of a background, we had a biochemical testing also done for them, and the Hurler enzyme came back as normal. The beta glucuronidase came back as normal, while aryl sulfatase B was quite low. So because of this biochemical support which we had, we tried the in-house inborn error metabolism panel, and targeted NGS analysis was done. So for which includes all these lysosomal storage disorder genes, and we could detect there is a single base pair deletion in exon 1 of the ARSB gene. So Sanger sequencing was also done, and this was confirmed case of MPS type 6. So another variant which was found in the GUSP gene, which causes MPS 7, was disregarded. So as far as possible, this is the message, that biochemical test radiographs, and other similar tests which are relevant, when combined with the clinical phenotype and NGS data, can help us to get a correct diagnosis in cost-effective manner. So many of our patients are self-paid, they don't have insurance, and there is lack of funds or finance. So if we use our clinical acumen as well as the supportive testing, then we can arrive at a diagnosis with a targeted in-house panel, which can be cost effective. But one has to make sure that you use the correct sort of relevant investigations. For example, I have seen incidences where there is a typical Huntington case with family history of Huntington, but they have been chasing, doing MRI, doing PET scan, looking for paraneoplastic syndromes. So I would say to that extent, one may not go because it increases the financial burden, but you have to read and see which genetic test or which supportive evidence or test can help you reach a diagnosis. So this was case 5, where this is a 4-year, 4-month-old first child born to second degree consanguineous parents with right-sided tightness of lower limbs and upper limbs and difficulty in walking. The MRI, as you would probably would have made a guess, that you can see the bilateral extrapyramidal involvement of the basal ganglia, including the caudate nucleus, lentiform, and globus pallidus. So Leig's disease was suspected and MR spectroscopy was done, which showed an inverted MP. So whether to do a nuclear or a mitochondrial, that was a dilemma because of financial constraint. However, we went ahead with parallel testing because the mother was pregnant at that time. So the clinical exome, which checks for the nuclear genes, picked up a uncertain variant in one of the combined oxidative phosphorylation deficiency, EAR S2, and SAC S2, which is spastic ataxia, which again is of uncertain significance. However, because of the time constraints, a mitochondrial genome was also done, and a homoplasmic missense variation in the MTND6 gene was detected, which had been associated with Leig's disease. So this is a likely pathogenic variant. So one must consider mitochondrial DNA as well as imprinting disorders, which fall into the category of non-Mendelian inheritance, while ordering or while doing a test for which is NGS based, because sometimes you may not get anything out of the clinical exome or whole exome because it's a different phenomena or a different mechanism. So now this is the last case. So this is the 6th case where we deal with rare variants. So this was a 3-year, 1-month-old child, again born to 3rd degree consanguineous parents. And at birth, the parents had noticed that the legs were bent. The neonatal period was uneventful. The developmental milestones were appropriate according to mother. In addition, there was this slow growth and short stature was detected from early childhood, from 1 year of age, along with mild pose face, hypertelorism, depressed nasal bridge, and large philtrum. And there was a short neck, protuberant abdomen, exaggerated lordosis, genu valgum, laxity of wrist joint, and she had waddling gait on examination. So although I have consent for her photographs, but I don't really like to share the photographs because this family, especially the mother, has undergone a lot of trauma ever since this child was born. So the skeletal radiographs, we can see that there is a genu valgum which is increasing. There is bending of bones which is coming slowly, and there's epiphyseal problems. There is these small ovoid shaped vertebral bodies on the X-ray, and also you can see the abnormalities on the hand and the wrist. So with this, we had they had undergone trio-exome sequencing, and a homozygous nonsense variation in exon 5 of the PRKG2 gene, which results in stop codon and premature truncation of the protein, was found. And the parents are heterozygous for this. Now, this variant is of low, has not been reported in 1,000 genomes, but this variant or this gene has been demarcated in a microdeletion syndrome, which has been described in 2010 in Journal of Medical Genetics. But there were 4 other genes involved because there was a microdeletion of 4q21 region, and those reports had, along with growth restriction, mental retardation, and absent or severe delayed speech. But our case had no such thing except for short stature. So genetic counseling became difficult because this variant has not been described in human beings individually, though it has been reported in animals. Now, ever since there was a diagnosis or there was an abnormality found in this family, there has been a lot of issues because the father separated and the father is now married, has another child, and the looking after or the care for this child has been solely by the mother and the maternal grandmother. So because there is a complex issue, as we do not know how this disease or this variation will further lead to problems, but what we can see is that she is already developing bent bones. So they actually wanted some sort of a report where we can say that this is going to cause problem in the long term. So apart from the stigma of short stature, there is also corrective surgery which is needed, and she has been from her time of birth or very early childhood has been seeing a pediatric orthopedician at our place, and she may need a corrective surgery. So we have to anticipate and see that what all can happen, whether there is some sort of a phenotype which can evolve, and also keep on looking at the literature and search databases such as ClinVar or other sort of databases where or Gene Matcher, where such reports or isolated cases have been reported. So in summary, we can say that each case is different, each family is different, and variants are different. So we have to decide on an individualized basis what should we do and how to counsel so that it doesn't add to the trauma of the family or the patient. So now we see that genetic testing has become part of clinical medicine. All specialties and everywhere, next generation sequencing is becoming a part. But one must remember that genetic counseling is a prerequisite before and after the test is ordered. And don't forget the patient and the family and the painful journey that has brought them to you. So the attitude toward genetic variation needs to be changed, because all of us carry some sort of a variation, and there will be so many variations which can be seen and which can modify our life or our health. So we have to remove that stigma and counsel them so that we can alleviate the mental stress or the psychological stress they have been undergoing with this diagnostic odyssey. So with that, I think I would like to end the session and would welcome any questions.
Thank you so much, madam. was a fantastic talk. I think you have given a very comprehensive utility of genetic counseling and how it has to be used in the present era of next generation sequencing. So I'm just looking at questions, anything on the board. I don't see any questions popping up. Audience, any questions?
Audience, you can use the Q&A window for any questions, or if you raise your hands, I can allow you to speak. We're getting mostly compliments for the talk.
There is a question from Dr. Simar Rajan Singh. How to proceed when proband has compound heterozygous mutation in 2 variants of same gene? Madam?
I think if there is a compound heterozygous mutation, then you have to proceed with parental validation and see whether they are in the cis or in the trans. So I think Dr. Sheila already mentioned such case. And we also discussed that if it is a compound heterozygous, then if there are 2 variants, you have to first validate in the parents to see how they are, in which position they are. They are like is a cis or in a trans.
There is another question. Along with NGS, whether we need to use CMA also to find out the reason of RPL.
You mean RPL means recurrent pregnancy loss? Then I don't think we are using NGS to find out any cause of RPL. It will be tremendous job, a very arduous job to see all the variants. So personally, I would not do an NGS for RPL. And CMA also, and we first go ahead with karyotype, and then if we find something, then we may need, but routinely first step, we would not use CMA. Because again, there are a lot of polymorphic variants or copy number variants, which can lead to confusion.
You do genetic study in cleft lip and palate children.
Yes, we have to first see the phenotype, whether there are any other associated congenital anomalies, whether there is a family history, whether sometimes there is one condition called Van der Wood syndrome, where they have lip pits along with the cleft lip and palate, which can be very variable. So in those cases, we would definitely do a genetic study. But having said that, cleft lip and palate are otherwise multifactorial. So it has to be a case-based approach. You have to take family history, examine the patient thoroughly from head to toe, see if there are any other things which can give a syndromic diagnosis, and then go in for testing if needed. But not in all cases. You have to examine and see the family history as well.
Thank you, madam. I don't see any more question.
Srinivasan, there's one question in the chat window.
Chat window, okay. 1 second. Which technique, NGS or microarray, yields better results for DSD in newborns?
Usually a karyotype would be best because it can pick up mosaicism, which can often be missed by microarray. So once our fish to look for more cells. So that is what we would do, a karyotype for newborns.
Okay. I think thanks a lot, madam.
I think one question is there in floppy baby syndrome, what test should be given? Yeah, so the common cause of floppy baby, the most common genetic cause is spinal muscular atrophy. But I think the best method to rule out a spinal muscular atrophy is by MLPA. So a clinical exome or a whole exome may still miss it out. A clinical exome definitely will miss out. So you have to do an MLPA for SMN gene, which is a common cause of floppy baby. Other causes you have to rule out if there is a congenital muscular dystrophy or a congenital myopathy, or there is a congenital myotonic dystrophy. Depending on that, you have to order the test. So in summary, like there is no there is no single genetic test which will give you all answers. You have to see, and it has to be a case-based approach for genetic testing also. In some, preferably you have to do karyotype. In some, you have to do chromosomal microarray. In some, you have to do whole exome or clinical exome. In some, you have to do mitochondrial. So it is, you cannot give one single gene which will cover everything. In some like triplet repeat, you have to do TP-PCR. So it's really not a generalized statement or a test where we can do it.
Suraj, can you, hello?
Yes.
Hello. Joseph, can you allow?
Yeah, I've just given permission to
who wants
Surya.
to
Yeah, he can unmute himself and ask for a question. Surya, you can go ahead. You can unmute yourself and ask a question.
Me now? Yeah.
Yeah.
Yeah. Madam, my name is Surya. I'm 54 years old. I'm suffering from muscular dystrophy. See, when I was 14, I got test. I was diagnosed as polymyositis. Then later in 2000, I went for biopsy test, madam. They diagnosed as muscular dystrophy. In 2017, I went for comprehensive neuromuscular disorder panel test, tested with 121 genes. But I got an inconclusive report, madam, saying 6 genes are VOUS. See, now I'm not in a position to go for whole exome sequencing or whole genome sequencing. What advice you can give to me, madam? See, is there any even I have a doubt whether I have a mitochondrial deficiency or something like that. I don't know how to go about hereafter. So can you answer my question, please?
Yeah, was any immunohistochemistry done in your muscle biopsy?
Yes, madam. Yes.
So maybe you can email me the report and then I can talk to you.
Yes, madam.
I will type my email ID.
Yeah, please.
I think by the time Dr. Sumita does that, so we will, probably conclude our session, and we'll ask our representatives to probably get in touch with you, Mr. Surya, and facilitate that.
Yeah, I think that will be good.
Yeah. So once again, so on behalf of MedGenome, I'd like to thank our speakers. We had two eminent speakers today, Dr. Sheila Nambudri and Dr. Sunita Danda. We really privileged to have you give us this webinar, and we thank you
Hello,
for taking time from
excuse
your busy
me.
schedule
Hello.
and answering this question and giving us this presentation. So on behalf of MedGenome, I also like to thank Dr. Srinivasan for moderating this session. And if you have any questions or comments, you can write into us at diagnostics@medgenome.com or call us at 1-800-103-3691. And if you have any further questions, you can write into us at this email ID, or you can give us this give us a call, and we'll have somebody call you back. So Mr. Surya, her email ID is sdanda@cmcvellore.ac.in. So please make a note of it. It's in the chat window. So we will sign off now. And so once again, thank you, audience, for participating, registering, and participating in this webinar. We'll have more of these in the future, and we look forward to your active participation. So thank you very much, and I'll be concluding this session. Thank you again, and have a nice day.
Thank you. Thank you.
Thank you. Thank you, ma'am.